everybody, and welcome back. It's great to be back with you here on my super nerdy emergency medicine channel. I hope that you're all staying warm and having a great year so far. This talk was originally written to give as a lecture for the Emergencies in Medicine conference in Park City, Utah this February. But there are a couple of really important papers in here involving some great topics in emergency medicine, such as the use of epinephrine for cardiac arrest and the management of fluids for kids with diabetic ketoacidosis. So I wanted to share this talk with all of you too. Let's dive in. This talk involves kind of a medium-ish dive into three of the most important papers published in the last year. We'll discuss the role of epinephrine for out-of-hospital cardiac arrest, and we'll look at another paper involving an interesting option for the treatment of nausea and vomiting. And last, we'll look at a paper reviewing fluid administration for pediatric DKA. I love creativity, and one of the things that always makes me laugh is people who have a sense of humor when they're naming their business. So for our mental breaks this month, here are some creatively named business ventures, starting with that seating emporium, the Shack of Sit. The first topic I want to talk about today is one that we spend a ton of time talking about, a ton of time thinking about, and a ton of time training to manage, yet for which we have a shockingly small amount of actual good quality clinical data to guide our practice. And that is sudden cardiac arrest. Specifically, I'd like to talk about the use of epinephrine for cardiac arrest, since the use of epi has been one of the cornerstones of advanced resuscitation since the 1960s, when a few studies using dogs demonstrated an increase in ROSC when supranormal doses of epinephrine were given in cardiac arrest. The theory is that epinephrine may be beneficial because of its alpha effects, namely peripheral vasoconstriction, thereby increasing aortic diastolic pressure and subsequently increasing coronary artery perfusion. However, this has to be weighed relative to its potentially deleterious beta effects, which include decreased peripheral and microcirculation to the vital organs, including the brain, increased cardiac oxygen demand, and increased arrhythmogenesis, all of which decrease the likelihood of a favorable neurologic outcome. Considering that it has been 50 years since epinephrine was adopted as a treatment, there is a relative dearth of high-quality data examining its use. In 2004, Ian Steele rocked the resuscitation world with the results of the OPALS trial that demonstrated that all of the extra crap we do with ACLS and advanced life support medics demonstrated no improvement in survival. In 2011, Jacobs and his excellent team found that giving epi improved return of spontaneous circulation, but did not lead to an overall improvement in survival to hospital discharge. Other observational data similarly demonstrates increased return of spontaneous circulation, but no improvement in neurologically intact survival. In fact, the only treatments that have proven effective in improving survival with good functional outcome are early defibrillation and early, high-quality compressions. Enter the Paramedic 2 trial. The Paramedic 2 trial might be the most important paper published on the management of out-of-hospital cardiac arrest in, well, forever. It's also the first randomized controlled trial to look at the use of epinephrine for out-of-hospital cardiac arrest in almost a decade. And more importantly, it's the first trial that really considers functional neurologic recovery as an outcome measure. Paramedic 2 was a randomized controlled trial done in the UK that compared the use of epinephrine versus placebo in out-of-hospital cardiac arrest. Patients were randomized to get either IV epinephrine, 1 milligram every 3 to 5 minutes as per standard ACLS protocol, or a saline placebo IV every 3 to 5 minutes. Importantly, it was double-blinded, so the treating providers did not know which of the two interventions the patient was getting. The primary outcome was survival at 30 days, but they included some very important secondary outcomes such as survival to hospital admission, survival at hospital discharge and at 3 months, and the one we all really care about, neurologic outcome at hospital discharge and at 3 months. The authors enrolled 8,014 patients, with 4,015 in the epinephrine group and 3,999 in the placebo group. And as you can see, they had very evenly matched groups, so the randomization worked well. About half the patients had a witnessed arrest, and almost 60% got bystander CPR. They also had a very low rate of shockable rhythms in this study, but that occurred because patients were not actually randomized until the trial packs of epi were opened. So if the patient had a shockable rhythm and achieved ROSC with initial defibrillation, the patient was never enrolled. So this trial only enrolled a very sick cohort of patients that failed initial defibrillation. As you can see, early outcomes favored the epinephrine group, as the epinephrine patients had substantially higher rates of return of spontaneous circulation and survival to hospital admission. This is consistent with the data on epinephrine from prior observational trials that demonstrated a higher rate of survival to hospital admission in patients treated with epinephrine. However, when we look at survival to discharge and at 3 months, there was less than a 1% absolute difference between the epinephrine and placebo groups. This was statistically significant since the number of patients in the study included was so large, but with a really large number needed to treat of 112, meaning that you need to treat 112 people with epinephrine to get 1 extra survivor. More importantly, the differences between the groups were much smaller when we considered neurologically favorable survival, and the differences here were not statistically significant. Let's look a little bit more closely at what neurologically intact survival looked like in this trial. The authors defined a favorable neurologic outcome as a Rankin score of 0 to 3, since with this score you're still fairly functional. Just as a quick recap, with the modified Rankin score, 0 is no deficit at all. With a 1, the deficits are so minor you need a neurologist to find it. A 2, the patient has minor deficits but can still live independently. And with a 3, you have enough deficits that you need some help with your activities of daily living, but you're still able to walk. A 4 means you need help with all of your activities of daily living and need assistance to stand or walk. A 5 is probably the worst thing we can imagine, the neurologically devastated, bed-bound patient that is incontinent and requires constant care. And a 6 means that you're dead. The overwhelming majority of patients in this study were a Rankin 6, which makes sense because the overall survival was pretty low. However, as you can see, there were no statistical differences in the number of patients with a Rankin score of 0 to 3, with 2.1% of the patients in the epinephrine group versus 1.6% of the placebo group. Let's put aside the patients that died and look more closely at the neurologic outcomes of the survivors. When we look at the breakdown of what percent of the survivors from each group had what Rankin score, it's clear that the placebo group had a substantially higher percentage of neurologically intact survivors. In fact, 31% of the epinephrine group survivors had severe neurologic impairment versus only 17.6% of the placebo group. So if you survived, you were twice as likely to have severe neurologic impairment if you got epinephrine. What this means is that although there were more survivors in the epinephrine group, the increased number of survivors were unfortunately made up by neurologically devastated patients. One of my favorite things they did with this study is that before they even started enrolling, they asked patients what they thought was important. Overwhelmingly, patients felt that long-term survival without brain damage was by far the most desirable outcome, with short-term survival to hospital admission being by far the least important. One of the arguments I hear frequently when discussing this is, just get them to the ICU and give the family some time to come to terms with it. It turns out that this isn't what patients and their families value. The authors acknowledge this in their paper, stating, Patients may be less willing to accept burdensome treatments if the chances of recovery are small or the risk of survival with an impaired neurologic outcome is high. Considering that this is what our patients value and how scarce and valuable our ICU resources are, I think we need to consider this in the calculus of how we manage our cardiac arrest patients. There are a couple of other things I think we need to consider before we abandon epi entirely, but the two that I want to focus on here are timing and dose. Our understanding of cardiac arrest is always evolving. Although most of our resuscitation protocols are primarily based on analysis of the presenting rhythm, it's important to understand that cardiac arrest is not a static process, so we also have to consider the duration of the arrest, as this also has an impact on the physiology of the patient, and it can be helpful to think about it in terms of different phases. The first is the electrical phase, the first 4 to 5 minutes following arrest, during which time the heart is most sensitive to defibrillation, hence the success of programs promoting access to AEDs, as well as the success of implanted defibrillator devices. Phase 2 is the circulatory phase, approximately the next 10 minutes following arrest, during which techniques such as high-quality chest compressions are needed to maintain oxygenation and tissue perfusion, with the goal of supporting the individual until defibrillation or return of spontaneous circulation can be achieved. The last is the metabolic phase. This phase begins approximately 10 to 15 minutes into the arrest, after which time the likelihood of successful resuscitation begins to decline rapidly due to the cumulative effects of global ischemia. During this time, vasoconstrictors like epinephrine, which may potentially be helpful during the circulatory phase, may result in worsening organ ischemia, particularly in the brain and in the splanchnic beds, leading to decreased survival. Other factors, such as worsening tissue acidosis, release of immune mediators, and reperfusion injury also contribute to the rapid decline in survival. This trial was of patients with out-of-hospital cardiac arrest, where on average it took about 20 minutes for bystanders to recognize the arrest, call for help, EMS to arrive, start resuscitation, get access, and administer the first doses of epinephrine. Considering that the majority of the patients in this study were already entering the metabolic phase of arrest by the time epinephrine was administered, it's understandable why the survival rates were so low overall, as the patients that could be rescued from the electrical and circulatory phases with defibrillation and compressions alone were excluded. Would it change things if epi was given in that first 0 to 10 minutes, as may occur in an in-hospital cardiac arrest? This paper does provide us with an answer for out-of-hospital cardiac arrest, but we don't know the answer to the question regarding in-hospital cardiac arrest. Now, let's consider the question of dose. This trial used standard ACLS dosing of 1 milligram of epinephrine every 3 to 5 minutes. That dosing is based entirely on convention, and there is really no evidence looking at the optimal dosing strategy for epinephrine. Maybe we need to consider smaller, more titratable doses? Perhaps popping in an arterial line and titrating an epi drip to some mean arterial pressure? Again, this hasn't been looked at in a randomized trial for cardiac arrest, so it's possible that it's not the drug, but how we're using it that's wrong. The bottom line is that for out-of-hospital cardiac arrest, epinephrine saves the heart, but it kills the brain. All of the data we have to date, including both prior observational data and the Paramedic 2 trial, demonstrate that the use of epinephrine for out-of-hospital cardiac arrest does not result in an improvement in neurologically intact survival. And I truly hope that this will be considered in the next couple of years when it's time for the AHA to revise their guidelines. Even if you think that survival, regardless of neurologic outcome, is important, these numbers needed to treat clearly demonstrate that we have other, more important interventions which are much more likely to result in survival at 30 days. So don't let a focus on epinephrine distract you from the other interventions which are much more likely to make a difference. How has this impacted my practice? For out-of-hospital cardiac arrest, it's very rare for a patient to get to me within that first 10 to 15 minutes of arrest, when they're still in the electrical or circulatory phase of their arrest, during which time they're most likely to be responsive to epinephrine. By the time they get to hospital, they're almost invariably at least 20 or 30 minutes down and about 4 to 5 amps of epi into the EMS resuscitation, which is well into the metabolic phase where additional epinephrine is probably going to be more harmful than good because of the unwanted beta effects of epi on the microvasculature. So I don't use epi in these patients anymore. If I have a patient that arrests right in front of me in the ED, I probably will continue to use epi during that first 10 or 15 minutes of arrest, but I also have the benefit of doing things like looking at the heart with an ultrasound, putting in an art line to see if the patient is actually in arrest, or maybe just profoundly hypotensive and in need of an epi drip. ACLS is great, but I think in the ED, we need to evolve beyond these protocols and think more critically about our cardiac arrest patients. Time for a mental break, featuring the Big Ass Fans Company, producers of some truly big-ass fans. This one's going to be a quick one. Aromatherapy versus oral ondansetron for nausea and vomiting. I think this paper is great because we all know and pity that poor patient that comes in clutching a bucket and barfing up their toenails. This paper was published in the Annals in August, and it's a small trial but was a single-center, randomized, placebo-controlled trial of adult patients presenting to the ED complaining of nausea and vomiting. They enrolled 120 patients in a convenience sample and randomized them to one of 3 treatment arms, with 40 patients assigned to each group. The first group got inhaled isopropyl and 4 milligrams of oral ondansetron, so they got both. The second group got inhaled placebo and oral ondansetron, and the third group got inhaled isopropyl and an oral placebo. My biggest gripe with this trial is they really needed a placebo-placebo arm, but unfortunately they didn't do that in this trial. The primary outcome was nausea at 30 minutes, as rated on a visual analog scale. This was a small study, but the outcomes were really different between the groups. Both of the groups that included isopropyl had more than 3 times the reduction in nausea scores as ondansetron alone. Now, there have been plenty of studies that have called the effectiveness of ondansetron into question when used for nausea not associated with chemotherapy treatment, but I was surprised to see how ineffective it actually was in this paper. They looked at a few secondary outcomes as well, and suffice it to say that the isopropyl groups also had lower nausea scores at the time of discharge, required substantially less rescue antiemetics, and had overall higher satisfaction with the treatment of their nausea. They even reported greater reduction in pain at 30 minutes. So the bottom line for this paper is that isopropyl appears to work. This was a small study, but the results are similar to other small studies that have looked at this too. A real randomized controlled trial would be nice, but let's face it, nobody's going to sponsor a trial for an intervention that costs about $0.01 versus their fancy drug, so unless somebody gets a grant to study this, it ain't happening. But it's cheap, it's faster than anything else we can offer, and it appears to be effective. So grab one of these swabs and get your patients to huff it next time you've got a nauseated patient in triage. It just might help them feel a lot better. This mental break is brought to you by Ditcher, Quick, and Hyde, attorneys at law in divorce law. Our last paper comes to us from the PCARN Research Group, who have done some truly outstanding pediatric research in the past. This paper discusses a topic that we all feel a lot of stress about: managing kids with DKA. Specifically, managing fluids for these kids. Cerebral edema is relatively rare, but it is the feared complication of pediatric DKA, as the outcomes can be absolutely devastating for the child. When this complication does develop, blame is often levied at the emergency medicine physician, claiming that we were too aggressive in our fluid management of the patient, despite evidence suggesting that fluid administration probably has very little to do with the development of cerebral edema. Rather, it's probably due to abnormalities in cerebral perfusion and vascular changes from the inflammatory state that occurs during DKA. Since it's the sickest DKA kids that tend to develop cerebral edema, it makes sense that these sicker kids probably got more fluids, which is probably why it was assumed that rapid fluid repletion was the cause of the cerebral edema. This was a multi-center, randomized controlled trial with a 2x2 design. They enrolled kids aged 0 to 18 with DKA and randomized them to one of 4 treatment arms: fast rehydration with normal saline versus slow rehydration with normal saline, versus fast rehydration with half normal saline versus slow rehydration with half normal saline. Other than fluids, treatment was the same between all of the groups, with D5 getting added to the fluids when the glucose dropped below 2 to 300 and insulin infusion at 0.1 units per kilo per hour. Let's talk about exactly what they meant by fast and slow. Fast rehydration assumed a fluid deficit of 10% of the patient's body weight. They gave an initial bolus of 10 mL per kilo, followed by a second 10 mL per kilo bolus at the physician's discretion, and then ran an infusion for half the remaining deficit plus maintenance for the next 12 hours. The remaining deficit was then repleted by 48 hours. Slow hydration assumed a deficit of 5% of the patient's body weight. An initial bolus of 10 mL per kilo was given, but no additional boluses were allowed. The remaining fluid deficit was then repleted over 48 hours. I think it's important to point out that even the fast rehydration group really wasn't all that fast. They still repleted the kids over 48 hours and allowed up to a 20 mL per kilo IV bolus up front, which is a little bit more than I think most of us are doing right now, but it still really wasn't all that aggressive of a protocol. Just because this group was referred to as quote-unquote fast rehydration doesn't mean we can just dump fluids into these kids willy-nilly. It's important that we understand what they meant by fast so that we don't use this study as a license to dump 50 or 60 cc's per kilo into these kids in the first 12 hours. The primary outcome was deterioration of the neurologic status in the first 24 hours. There were several other secondary outcomes looking at short-term memory and IQ up to 6 months out, but I think the one we really care the most about was the development of clinically apparent brain injury, meaning a deterioration in neurologic status severe enough to require initiation of hyperosmolar therapy or intubation, or resulting in death. 1,255 children were randomized, but because 132 of the kids had 2 episodes of DKA, 1,389 episodes of DKA were assessed. There were no statistical differences for either outcome between any of the 4 rehydration strategy groups. Cerebral edema was, thankfully, a rare occurrence among all of the groups, with about 3 to 4% of the patients in each treatment arm having some decline in mental status in the first 24 hours, and only about 0.5 to 1% developing severe brain injury. This is clearly the best study we have on this to date, but there are still a few points to bear in mind when applying this data at the bedside. Number 1, a fair number of kids were excluded from enrollment for a variety of reasons. Either they already had a low GCS on presentation, so they met the primary outcome before they could even be enrolled, or kids got transferred in who had already been treated, parents didn't consent to enrollment, and there are a couple hundred kids that were excluded because the treating physician thought the kids needed some kind of special fluid management strategy and didn't think that either of the treatment arms available in the study were appropriate. This may have introduced some selection bias into the study. That being said, I think they did a good job of capturing the kids with the most common presentation for DKA, with well-balanced treatment arms, so it's hard for me to criticize the authors very much on this point. Number 2, the study included kids from age 0 to 18. This is both good and bad. It's important to look at this concern across all age groups, but I'm not sure we can say that a 2-year-old is physiologically the same as a 17-year-old. Unfortunately, it's really the younger age group where this is the biggest concern, so it would have been nice if they had focused more on this particular age group. As we mentioned earlier, even the fast rehydration group wasn't all that fast, so this paper still used fairly conservative rehydration strategies in both arms. The reason for this is that in order to get the study approved, they had to pick 2 rehydration strategies on the extreme ends of what is currently considered accepted practice. I think that since they did not demonstrate any harm in either group, this could potentially open the door to future researchers to consider more aggressive rehydration strategies similar to what we use in adults. But this trial didn't address that question, so I think we still need to be conservative in our approach to these patients. Like I said before, this is the best evidence we have to date, and this is probably the best evidence we're going to have for a very long time to come, that fluid choice and rate of administration within the parameters of the study don't cause cerebral edema in kids with DKA. This is further evidenced by the fact that they excluded 109 kids from enrollment because they had neurologic deterioration or cerebral edema before any treatment was even initiated. In fact, while the differences were not significant, if anything, the rates of deterioration were actually lower in the fast rehydration group. It makes me wonder if maybe rehydrating these kids even a little bit faster and getting them a little less sick sooner might actually reduce the incidence of cerebral edema. But I sincerely doubt that that study is going to be done anytime soon. Cerebral edema is just a rare enough occurrence that it's going to take a study of tens of thousands of kids to definitively find a difference. And that happening anytime soon is about as likely as me riding a unicorn to work tomorrow. So this is probably the best evidence we're going to have for a very long time. That about wraps it up for this time. I'll leave you with the appropriate way to name your Vietnamese noodle soup joint. And on that note, thanks for listening. See you next time.